So, coming to Introduction to MRCOG Part 3. So, for those who are planning to take exam in May, it's important that you at least start your preparations, collecting material, following a particular set of a routine, which would go in a long way to contribute to your MRCOG Part 3 preparation, because this is not the same type of exam that you have always answered. This is not the EMQ or SBA type of exam. This is not just an objective kind of an exam. You need to be able to communicate what you know already, which you were assessed for in MRCOG Part 2. So you should be able to communicate well to your role player, to your examiner. So it is about not just communicating, but it is about communicating in an effective manner and portraying your knowledge as well as proving that you are a safe ST5. So this is really, really important when it comes to MRCOG Part 3 exam. All right. So what are the keys? What are the important aspects of MRCOG exam? So as we all know, we have 14 tasks. All right. And all these 14 tasks would be a back-to-back. All right. And there are cubicles, the on-site exam. Earlier we had online exam during COVID time, but now we have the on-site exam. So you have 14 tasks back to back, and you have 2 minutes, 2 minutes reading and 10 minutes for you to do the task. So we all know about this, right? There are key competencies that are being assessed, which includes information gathering, communication, patient safety, applied clinical knowledge. Okay. There are certain strategies that we need to master, like structuring the answer, time management, building your confidence, and that is important that you build your confidence. And also, there are various tips that you should be following, and that should happen right from now. All right, the tips that we would be telling you, you need to put it into your daily practice from now. All right, and only then will you be able to master the exam. All right, so coming to the MRCOG exam, as we know, that is from part 1, part 2, and part 3. This is not important. So there is a critical shift, as I discussed earlier. Knowledge alone isn't enough, and you must demonstrate your clinical competence, your professional communication, safe decision making under pressure, empathy, and patient centered care. And this is really, really important, because when we talk about guidelines, there is a particular way in which you manage a particular task. For example, when you have a case of fibroid, you have your expectant management, you have the medical management, you also have surgeries. Okay. But in a patient situation, you will not apply all of these management options to one particular patient. And that is important for us to know, because we have a lot of candidates asking us, okay, so there is this case with heavy menstrual bleeding with fibroid, and I spoke about everything I knew. It is not about speaking everything. It is patient-centered care. And this is something that we must understand. Okay. The patient may be having heavy menstrual bleeding with submucosal fibroid. In that case, you are not going to utter the word expectant management. You need to treat that fibroid, and you may require a surgical correction or a surgical treatment for that particular fibroid is something that we all must remember. So patient-centric treatment. Just like a patient walks into your clinic, and what you would do, you would take her necessary history, you would tell her, okay, for you, this is the treatment option that we would be considering, or we would be planning for you this particular treatment option. Not all treatment options can apply to in all situations. So this is something that we must remember. It is holistic approach for a particular patient. Secondly, there may be other factors. She may be requiring fertility. You cannot just put her on medical management and end it there. If she requires fertility, you need to stop the medical management at some point in time. And you need to consider maybe a surgery to get that fibroid out so that that improves her fertility outcome. So you have to consider the fertility desire of the patient. You have to consider whether she's anemic or not, because if she's anemic, you cannot operate directly. All these factors are important, and that is how we would train you for knowing or identifying situations that would require situation specific treatment. Okay, not everything applies in all situations. And it is not just enough to know how to say, the communication part and keep on emphasizing on communication. That is another important problem that we face when we have candidates, okay, that come for courses. We need to tell them that you do not overdo the communication. Yes, it's important to empathize, it's important to sympathize, but the moment you do that, the examiner will tick in his answer key that you have already done that. Okay, if you keep on doing that, I'm really sorry that you're going through so much, and we are here to help you, etc., etc. If you keep on saying, because you want to show the examiner that you are communicating well, what you're going to do is, in the bargain, you're going to compromise on patient safety and applied clinical knowledge. And that is how some of the candidates do not do well in patient safety and applied clinical knowledge, because they overdo the communication part. Even when we have candidates for answering the mock exam, then they will tell us that this is something that we didn't know earlier. Okay, this is an eye opener. I kept on communicating well, and in the bargain, I compromised on patient safety, and I did not get time to finish the task. And that is because we keep on talking about, yes, you have to talk well, you have to empathize, you have to give her adequate breaks so that there is time for the patient to comprehend the information that you have given. But that doesn't mean that you keep on scoring on communication and compromising safety and applied clinical knowledge. Okay, so it is not just communication that is being assessed, is what I'm trying to tell you. It is safe decision making, professional communication, real world clinical competency, okay, in a particular situation, and patient centered care. This is the basic essence of MRCOG Part 3. And this is how MRCOG Part 3 differs from MRCOG Part 2 or Part 1. It is not just a single answer. It cannot be a straightforward answer. It has to be situation specific answer. And at times there may be a difference of opinion, and that's completely fine. If there is a difference of opinion, as long as you justify why you think this particular management option may not be ideal for a particular patient. Just for example, there was a station which we were discussing in our course. In May 2025, there was a station where you have an 18 weeks pregnancy, IVF conception, and she's come with leaking. Okay, so if there is this patient who's come with a precious pregnancy, she's come with leaking at 18 weeks, her CRP is increased. She's likely to be having an infection. You have to be realistic with the patient. You cannot say that we will follow expectant management blindly, like you would do in other cases of PPRN. You need to tell her that at 18 weeks, if there is leaking, the prognosis or the outlook, the word that we use in MRCOG Part 3 can be outlook rather than saying prognosis, for the baby is likely to be extremely poor. Even if we continue the pregnancy, there is a very good chance that you could go in labor early, and the baby may not make it because it's too premature. At this point in time, we have noted that your infection risk is high, the CRP is high, the infection may already be setting in. So we may need to consider delivery as a life-saving measure. So you have to be realistic. You cannot, just because the guideline on PROM or PPROM says that you can continue expectant management, you can consider delivery after giving steroids, etc. At 18 weeks, that will not usually work. So first you tell her what you would suggest, what is safe. First is safety. So whenever you're deciding a management option for a patient. Patient may not want it, and typically they will give you a task where the patient says that no, I don't want to deliver right now, even if it is for her own safety. It's about how you try and negotiate with the patient. So you say that this is the concern, this is the safety concern. I can understand that you really want to continue this pregnancy, but even if you do continue the pregnancy may not go far ahead enough so that so as to get a baby that is viable. Okay, so you need to be realistic in your negotiation. You have to be giving her the facts. You cannot just create a rosy picture in front of her and say that okay, you can go ahead with the pregnancy. Okay, so that is something that we all must remember at all times. Okay. All right, I think I was not sharing the, okay. I hope you can see now. Can you see my screen? Yeah, I think I had paused the screen sharing. All right, so what I was talking about are the fundamental principles that they are testing your competency, they are testing the professional communication, the decision-making capacity, empathy, and patient-centric care. All right, now, so we have already seen this. There are two types of tasks. So you have simulated patient task, simulated colleague task, you have structured discussions. Okay. Now we all know what a simulated patient task is. It is important for you to note when you enter the cubicle, whether it is a simulated patient task or a structured discussion. And that is the first thing that you would notice in your circuit that you answer. Okay, of course, we would be coming to that in detail when we go to the individual tasks. Okay, so the 5 essential domains that we have, and typically a station would assess at least 4 domains or sometimes 3 domains. In a structured discussion, you may not always have information gathering. Okay, so you may have information gathering, communication with patient, applied clinical knowledge, and patient safety in simulated patient task, and that is the norm. You always have these 4 domains in a simulated patient task. On the other hand, in structured discussion, you have patient communication with a colleague, patient safety, and applied clinical knowledge, usually. If there is information gathering, then you have a 4th domain, which is information gathering. That means that simulated patient task will always have 4 domains. They would get more weightage in the exam, more marks, right? A structured discussion which has 4 domains will also have more weightage, but there are structured discussions that have just 3 domains. Those structured discussions will have lesser weightage in the exam. In the exam, you will also have lay examiner tasks, and the lay examiner may also assess certain domains, okay, like the communication, particularly with the patient, applied clinical knowledge, and safety as your patient safety as well. So there are these are the things that the lay examiner, who is a non-medical professional, would also assess in your MRCOG Part 3 tasks, and the tasks that have a lay examiner would be the task that has maximum weightage in your exam. So that particular task has to really go well. All right, so that task has to really go well. So you have the lay examiner assessing the domains, you have the actual examiner, the professional examiner assessing the domains, and you will in the structured discussion, you will just have one person sitting there. That's how you identify. Sometimes in that anxiety, you tend to miss whether it is a structured discussion or a simulated patient task. So how you know? In a simulated patient task, there will at least be 2 people sitting there, at least 2 people. Okay, one will be the examiner, the other will be the patient, role player. Sometimes 3 when you have a lay examiner, and those are the tasks that you really should be doing well. Okay, structured discussions, on the other hand, will usually have 1 person sitting there. That's the examiner who's asking you questions. All right, so that is about it. So you have patient safety. It's important to say a um, few terminologies that are, we are considered as the buzzwords in your tasks, like whenever applicable, say MDT, say I would give you a PIL, counselors, support groups, consultant input in care. So all of these points are likely to make you a safe ST5. Okay, so wherever applicable, these certain points should be kept at the back of your mind. Okay, so like for example, if there's this situation that I gave you when there is infection setting in and there is leaking, whether you consider her life as priority or not, whether you talk about expectant management without any reservations and without telling her that it may not be safe, that is something that they are looking for. They are looking for a safe SD5. So that's the safety bit. Like when there is a RH negative pregnancy, whether you're giving her NTD, not giving her NTD, these things are considered in safety. Of course, the description of complications, how the procedure would be done, for example, in procedure like hysteroscopy, how a hysteroscopic procedure would be done, what are the complications, what are the complications in her situation, her specific situation, okay, what problem she could face in her specific situation, that would be applied clinical knowledge. Of course, we have detailed videos on our YouTube channel. I'll share with you in a bit detailed videos, what domains or what points are assessed in patient safety in the various modules. Okay, so we have those on our YouTube channel. You can go through those videos before you start your preparation. Why this is important? The orientation is important now because most of us do not know where to start, how to start. That is why this is important. All right. So safety, applied clinical knowledge is basically the knowledge. Information gathering is not just history. Remember that. This is a typical mistake made by most candidates despite telling repeatedly. Information gathering is history, it's examination as well as investigations. Of course, in a simulated patient task, as you are talking to your role player, you're likely to talk about history and you're going to say examination. You're probably going to say that I would like to run a few investigations for you, and these would be the investigations. But what can happen is in a structured discussion, when the first question that is put to you is what further information would you like to gather? The typical mistake is, I will take this history, end of story. No. Information gathering is history, examination, and investigations. Typical mistake. So please note down all these points that I'm saying. These are typical repeat mistakes that are done by candidates. Overdoing the communication is something that is like, there is a particular news that you have to break to the patient. All right. Like say, for example, there is cancer. Okay. Cancer of the cervix, for example, and you need to break it to the patient. So yes, you have to give warning shots. What is a warning shot? So rather than directly telling her that this is cancer, you need to tell her first that you need to warn her that, okay, there is something abnormal happening there. So you're not saying it is cancer in the first shot, but you're preparing her, you're prepping her for the blow that she's going to get. Okay. So initially you're telling her that there are certain cells that we have noted on that line the neck of the womb that are showing certain abnormal changes. That's the first warning shot. The second shot would be these abnormal cells are noted to be invading deeper into the tissue of the neck of the womb. Okay, so that is, you're saying that it is cancer. And then you say that this means that the report says, you also have to say that I've confirmed that this is your report with your name and NHS number, because that is also a safety point. If you report somebody else's, if you communicate somebody else's report to a wrong patient, that's not right. So that is why you have to say in your task that yes, I've confirmed that this is your report with your name and your NHS number. And I'm sorry to be saying this, but it appears that you have cancer of the neck of the womb. The moment you say this, your communication has been perfect and you have scored in communication. Don't keep on saying, I'm really sorry. I'm really sorry. I'm really sorry. No, You have to complete your task. So do not overdo the communication. At the same time, be clear and crisp. There are a lot of candidates who keep saying they may have picked it up from somewhere. They hesitate to say cancer. It would go against you if you hold that information from the patient. The patient has the right to know her diagnosis. So if you do not convey to the patient that it is cancer, that is extremely wrong. And most of us say there are certain sinister changes in your neck. What is sinister changes? Sinister is an English word. It does not mean cancer. Okay, a lot of our candidates say that, a lot of those who join the course. Okay, so by the time we finish the course, then they realize, okay, then we are not supposed to say sinister changes, we're supposed to say cancer. Okay, so you need to tell them that there are these certain abnormal changes. Give them a warning shot. They have invaded deeper into the tissue, and this means that you have cancer of the neck of the womb. I'm really sorry to be the bearer of this news. End of story. Give her a pause, wait for her to respond, and then continue with management, which starts with referral to cancer center, MDT. So you're ticking the patient safety points. Very important. Okay, so this is something that you must really understand. Do not overdo the communication. Keep it crisp, clear. Clear is in, do not say sinister changes for cancer. Say that it is cancer with adequate warning shot. At the same time, I'm going to tell you that do not directly tell her it's cancer. Do not tell her directly that it is IUD. Baby is dead. You have to give adequate warning shots, like the baby's movements are not there on scan. We noted that the heart of the baby was not beating. I'm really sorry to be saying this. It appears that the baby has died in the womb. This is how you would do your IUD station. All right. So, and at the same time, you need to complete it quickly. So crisp and clear. If you see our MRCOG videos, you will realize they are there on YouTube as well for you to see for free. So you will realize that the communication or the sentences are short. It's not lengthy material that is not possible for you to finish in 10 minutes. Okay. Now, you also have communication with, so we said communication with patient, patient safety, applied clinical knowledge, information gathering, and communication with colleague. This particular domain, which is communication with colleague, is extremely easy for you to score. That also means that it is extremely easy for you to get a 0 in communication with colleague. For example, if it's a structured discussion on cancer of the cervix and you have not mentioned referral to cancer center, you have not mentioned MDT, including oncosurgeon or oncologist or the specialist nurse, support groups, counselors. So these people, additional people that are usually involved, if you do not say that, you'll get a 0 in communication with colleagues. If you say this one sentence, you will get a full 2 in communication with colleagues because there are very few points. It's about which other people or personnel you are involving in the patient care or the patient's management. That is what is being assessed in communication with colleagues. All right. So it's important that you note that it's easy to score. At the same time, it is easy to lose. Always note the domains that are covered. So when you read the domains in your task, like it says a structured discussion and there is communication with colleague there. When you read those domains, you should know, okay, there is communication with colleague. I have to cover the colleague's part. I should not be forgetting. And that you practice. Otherwise, it's difficult. Last minute, you cannot just think of something like this. This has to go into your practice. Okay. So these are the 5 domains that are there, but stations will have 3 or 4 domains assessed, not all 5. All right. Now, so simulated scenarios you have, and you have a structured discussion. So as I mentioned earlier, you can make a mistake. There may be a patient situation given in the question, and you may think it is a patient scenario, simulated patient task. Okay, the one way of identifying for sure it is not simulated patient task, even if you've not read outside in the cubicle, is by seeing how many people are there. As you can see here, there are your three people in the cubicle, including the candidate. So that is then the first in the left-hand side. So that is your simulated patient task. So there is one examiner, one candidate, and the role player. Okay. While in a structured discussion, you have just the candidate and the examiner. So that's one way of identifying. Of course, don't worry. Your questions are pasted on the cubicle outside. There are cubicles as you go through your exam. There are cubicles that you would go from one cubicle to the other. That's a circuit. So the question would be pasted outside the cubicle for sure. And when you go into the cubicle to answer, the question would be pasted on the table that you sit at. Okay, so you will get to read your question, or you will get to check. If you think that you're confusing, you can always check. You can always take a moment, particularly if it's a structured discussion. If it's a simulated patient task, I would not suggest that you take a moment in the 10 minutes time, because you're anyway quite restricted. But in a structured discussion, typically it's possible to finish in even 8 minutes. So in that case, you can ask for more time. All right. So and that's about structured discussions and simulated patient. If the question is not clear, do not hesitate to ask the examiner to repeat the question. You can always say that, please, could you repeat the question for me? Simple, keep all your sentences short. Practice in this manner. Please, could you repeat the question for me? Okay, so the examiner can repeat the question and then you'll know. There. As the eligibility criteria, we all know you have to have your assessment of training before the Part 3 exam and Part 2 completion. You have a maximum of 4 attempts for the MRCOG Part 3. That means that if you fail 4 times MRCOG Part 3, you'll have to then repeat your MRCOG Part 2 exam. Okay, so let's come to some strategies for preparation. So like this is a task. This is a November 2025 task, which we were making for the library. We would be uploading all these tasks in our library. So this is the task that came on the second day of November exam. So what I have displayed this task for you, only for you to identify that what are the important points that you should be knowing. Okay, so you have the topmost important line is that it is a simulated patient task. That's the most important um, point to note, whether it is a structured discussion or a simulated patient task, because you are in that particular, even though you identify, okay, there's one person sitting there, so it's structured discussion, or there are two people. Yeah, but first in the 2 minutes time, you have to register whether it is simulated patient task or a structured discussion, so that you are mentally prepared. Okay, so you are mentally prepared. Then check what are the domains. Always check domains. Most of the candidates, what they do is they just read this part and they forget about the rest. No, never. Check what all domains. If it's a simulated patient task, yes, mostly you'll have all 4 domains there. If it's a structured discussion, you may have 3 domains. You may not have information gathering. But if you have information gathering, usually the first question would be what further information? And even if the patient or the examiner does not ask what further information, you know that there is information gathering because you have seen your domains. And then in the question, in the discussion, you have to incorporate history, at least the relevant history that is needed for your management. So that is why it is important, particularly in a structured discussion, to note what are the domains that are covered. All right, so the typical mistake is to jump directly to the body of the question. No. Okay, so first note what domains are covered, what task it is, and this part is important. All right, the task. What have they asked you to do? For example, it may be a simulated patient task. If it's a simulated patient task, usually what is asked is take history, address her concerns, and make a plan. Sometimes it is a simulated patient task, core surgical module. They will ask you, say, take consent for forceps delivery. Okay, you're shifting her to the theater for a mid-cavity forceps. Take consent for forceps delivery. So when they say take a formal consent for forceps delivery, you have to be prepared for writing the consent. That's why the task is important. Sometimes they will just say, counsel the lady for forceps delivery. That means you just have to talk to her about forceps. So that is why, please note this particular point, this particular part of the station is really, really important. Okay. Then the next thing that is important is you are the ST5 in the gynecology clinic. It's important where you are. Why? Because sometimes there would be a patient that you're seeing in the ward, admitted in the ward. Okay. It may not be right later to tell her, okay, you are having this situation, this particular problem. I am admitting you now. That will go against you. If the patient is already in the ward, admitted in the ward, please do not say that I'm admitting. If a patient you're seeing, say for example, preeclampsia, you are seeing her in the antenatal clinic and you found that the blood pressure is 160 by 110, her urine protein is 2 plus. Then if you don't say admission, you will probably fail the task. Okay, because admission is really, really important for a patient like that. Okay. But if it is mentioned to you that this patient is admitted to check for the evaluation of blood pressure and you are the ST5, you are called in to counsel her about the complications that she could have because of high blood pressure, and then you say, I will admit you, that will be lack of situational awareness. This is what it means, having situational awareness. Okay, you need to know where you are at what point in time. Okay, so also note the salient features given to you in the task. Like here it is mentioned that she's 40-year-old who is presented with heavy menstrual bleeding for the last 6 months. She has tried mefenamic acid and tranexamic acid. She's having history of DVT. She's on anticoagulant. So you have at the back of your mind, okay, maybe she's bleeding because she's on anticoagulant. Process this information. What I would suggest in the 2 minutes time, rather than noting points down, and saying, okay, this is what I'll do, this is what I'll do, this is what I'll do. You just process the information. You understand the clinical situation. The whole scenario is important to understand. Okay. So sometimes what you can do in your notepad is what we used to follow is just make you have a notepad with you and in the 2 minutes time you're reading the task. So you can make a grid, okay, in the notepad, and this would be IG, this would be PS, this would be ACK, okay, and communication with colleague or patient. So in IG, if there are certain things like here you have noted that she's having DVT. So you need to ask her about her anticoagulant. So some important salient points you note down that you would need. Those are asterisk points. Like for example, a case of chronic hypertension in pregnancy. You should not be forgetting to ask her aspirin, whether she's on aspirin. If you're seeing her later in the pregnancy, history of having been on aspirin is important. So those things you may note a little bit, a few points. Do not what to say, do not try to summarize the whole 10 minutes task in the 2 minutes time. Not possible. It's just not possible. So in the 2 minutes time, I would say that you register the information that is provided to you in the 2 minutes time. Reread the task, read and reread the task, understand the situation. Okay. And you can make this grid in your notepad, and do not forget certain safety points like allergies. Okay. Allergies. These are always there. BMI. Usually you will have obese patients in your circuit. Okay. Smoking, these things, how you'll remember to say these things is by practice. Have a particular set that you ask. Always when the patient presents to you with say this particular bleeding, you will ask history about the bleeding. Chief complaints, as we say. Chief complaints would include heavy menstrual bleeding, whether it is regular, whether it is irregular. Why is it important whether it is regular or irregular? Can anybody tell me? Why is it important? Heavy menstrual bleeding, regular, irregular bleeding. Yes? Can anybody tell me why? Anyone? Dr. Nandini, can you tell me since you were the first one to join?
You can rule out pregnancy.
That's there. What else?
Um, regular. It can also tell about the pattern, cause of the instrument. If it is intermenstrual bleeding or something like that, can be intercavitary lesion of the uterine cavity.
Excellent. That's one. And when I'm saying irregular means spaced out bleeding.
Sorry?
Anovulatory cycles with heavy bleeding.
Yeah.
Does that suggest something to you?
So it could be a, we can,
Yeah.
sorry,
Yes,
my
Dr.
daughter is around.
Shivani.
Yeah, we can, in the case of anovulatory, you can rule out PCOS and all the other risk factors, BMI, raised BMI. So we can go with the ahead of taking an endometrial biopsy in the direction we can go ahead.
Exactly, exactly. That is very important. We often miss taking endometrial biopsy. In fact, the NICE guidelines itself says that if there is irregularity, anovulatory cycles, spaced out cycles, they are hyperestrogenic states. And then you have heavy bleeding because it is hyperestrogenic, there is no progesterone to cement the estrogenic endometrium. Progesterone, remember, is the cementing agent for the endometrium, and estrogen is the building of bricks. Okay, so if you don't have the progesterone to cement the bricks, what will happen? The bricks will be built and it will all collapse irregularly, resulting in heavy bleeding. That is the pathology in irregular bleeding. So when you have this thickened endometrium, we need not always have a thickened endometrium on ultrasound, but when you have this history, you know that you have to go in with a hysteroscopy, even if it is a fibroid uterus, because you need to rule out endometrial hyperplasia. There could be cancer even. You need to rule that out before you treat the fibroid. All right. So that is why this history of chief complaints is important. Whether it is regular, whether it is irregular, whether there are intermenstrual bleeding, could be because of a polyp, could be because of a cervical pathology, postcoital bleeding. So all of these points are important. All right. So, and then you take a biopsy. So your management will change depending on that. And take relevant history. Do not take irrelevant history. Like we often have some candidates asking about history of smears in pregnancy. Okay. So patient has come with a complication in pregnancy, like say growth restriction, for example, or preeclampsia. Has nothing to do with cervical cancer. Okay, so can I just mute you, Dr. Shivani? Or Dr. Shivani, can you mute yourself? Your mic is on.
Sorry, sorry,
No
sorry, sorry.
problem. No problem. So, so what I was saying is that a lot of candidates will ask about smear history in antenatal, and that sounds irrelevant. Okay, so what I would suggest is ask only what is relevant, because the question itself or the task itself says you have to take relevant history. Okay, relevant history is what is mentioned in the task as well. All right, so stick to it. Okay, when they give you that the pregnancy is 9 weeks or 10 weeks, you need not ask LMP, because it is there is not going to be a situation where she is having irregular periods and then you'll have to sit in your task and calculate POG by ultrasound and calculate POG by your dates. That is not going to happen. In this is an exam at the end of the day. So you're not going to be given a scenario where there is irregularity and you cannot predict POG based on last menstrual period. You have to consider ultrasound dates and all those things. So it's not important asking for last menstrual period when the patient is telling you that I'm 9 weeks through the pregnancy. Similarly, unless it is a booking visit. In the booking visit, you have to ask all of the booking screening questions, like whether she's had exposure to any infection, whether she's had history of FGM. If you read all those guidelines, you will note that this particular history for FGM, particularly for those who have come from the high risk areas like African countries, you they will have those particular names. Okay, so you will need to ask if it is a booking visit, have you had any such history of being cut when you were younger? Okay, in a very empathetic manner. So that is all which is important, but you will usually not get a station that says this is the booking visit. You will typically get a station which says that the midwife has referred this patient to you with the problem, you address the problem. So just ask history which is relevant to that problem. Otherwise, you can just ask how the pregnancy has been so far. Are you having any complaints? You need not ask each of those complaints. Like, say it's a maternal medicine task. It's a vast task for you to cover in 10 minutes. Maternal medicine tasks are one of the longest tasks in the circuit. So she's come to you at 8 weeks with, say, Graves' disease, and you have to counsel her. Okay. Then you ask, since she's 8 weeks, you will ask her, are you nauseated? Are you having vomiting? Are you having lower tummy pain? Are you having spotting? No, avoid doing that. Just ask her, how has the pregnancy been so far? An open question. If there is a problem, ultimately it's a role player. It is not a real patient who is going to hide or forget things. Role player is trained to tell you, okay, this is something that you should tell your candidate. Okay, so you can just ask an open question. How has the pregnancy been so far? Do you have any specific complaints? End of story about the pregnancy. Go to your Graves' disease, which is the major thing that you need to address there. Okay, so this is how you save time by using open questions whenever relevant. That does not mean in a teaching task you're going to ask her open question. A lot of candidates do that. They, like, for example, if there is a station on teaching of CTG, you cannot be asking the role player or the colleague, okay, tell me what are the various decelerations. Okay, you cannot put that question first. You have to say what decelerations exist because you are being assessed. The role player is not being assessed in the task. Okay, so you are being assessed. And that is why you have to showcase your knowledge and then maybe ask her or him to repeat. That's different. But in a role player task, you can always ask her open question wherever that is applicable because it is a simulated role play. Okay, so ask her, pregnancy, how has your pregnancy been so far? Any particular complications known in the pregnancy? That's it. Okay, so there are smart ways of doing your stations faster. All right, now, uh, this is another station which was again in November on Doppler. Okay, quite a simple task, and it was kind of predicted that this particular circuit will have stations on the 2024 FGR guideline. Okay, you have the FGR guideline which has come in 2024. So it is kind of expected that you will have these tasks. So this is a task which is there, which was asked in the November exam, and about teaching. Okay, so here you have to note that it is a simulated colleague task. For teaching task, they will mention it is a simulated colleague task. Most other tasks will be simulated patient task. Here it will be mentioned simulated colleague task because you're teaching a colleague. Okay. That said, sometimes even a labor board prioritization task would have simulated colleague written on top. And what does that mean? It means that you are about to see one of the personnel who's posted in the labor ward, like your midwife coordinator or the senior midwife. So you are about to see your senior midwife, okay, is mentioned in the task. So that would be a simulated colleague task. So how you approach that task is going to be different from a structured discussion. In a structured discussion, you're going to say, okay, I'm ready for the structured discussion and proceed. You just greet the examiner. Hello, I'm so-and-so. I'm one of the candidates and I'm ready for the structured discussion. It's always nice to greet. You need not always do that. This is not something that is compulsory for you to do, but it gives a good impression when you greet the examiner. That is why you greet. Okay. So in a structured discussion, that is how you're going to start. But if it's a simulated colleague task, you're going to act like you're the ST5 posted in the labor ward. So you're going to say, hi, I'm the ST5. I'm posted here today on the labor ward. I believe you are the senior midwife. We could go through the labor ward board and discuss the management. This is how you're going to do if it's a simulated colleague task. And again, I would emphasize it is important to note what task it is. This is the reason. The way you approach a task would be different. In teaching task, it will be clearly mentioned here that you have to teach, or it will be mentioned here that you have to teach. Then it becomes very easy. But there are certain situations where they would just say that this is a simulated colleague task, which is actually like a structured discussion, but you are talking to your consultant. So then if you're talking to a consultant, you have to act like you're talking to your consultant. So good evening. I am the ST5, and I believe you wanted to discuss the task, the case with me. Okay, so we could proceed. So just start by greeting, or even if you say good evening, I'm the ST5 is also fine if it is a simulated colleague task. Okay, I hope this is clear with everyone. All right, you have any questions, please ask. But for now, you note down. You can ask on the group, or you can ask in the end of the session. No problem. All right. Now, so this is again the third station which came day before yesterday for the exam. So a structured discussion which shows on recurrent pregnancy loss or recurrent miscarriage. She has biconjugate, partial biconjugate uterus. So here you can see that there are 4 domains. Okay, if this was not there, then if there were 3 domains, then it is possible that they would just want to discuss the management, only the clinical management. But the very fact that this is there means you have to discuss history in detail, examination, investigations, 3 things. Okay, this is how noting the domains helps you always. All right, so this is these are the 3 types of tasks. You have SPTs, SCTs, that is simulated colleague tasks, and you have structured discussions. All right. Now, okay. So what should you do? The preparation timelines. Currently, we are at the first stage. This is foundation building. 4 to 6 months is foundation building. You have to know what syllabus, what are the guidelines, some study groups or courses, which course to choose, etc., would be at this stage. Okay, how much I'm going to invest, how much I'm going to invest for the exam, and how much I can invest for courses, what I can afford, what I cannot afford, all those things at this stage you need to assess. Okay, so you need to have an idea. Okay, these are the various guidelines, and I need summaries of these guidelines. Okay, you cannot read everything. It's not possible to read everything. If you go to read everything, you're not going to be able to practice, which is much more important. Okay, like I tell our candidates in the courses, do not read guidelines, just read whatever is mentioned in the library. That would be more than enough for you to pass your stations. Like in this exam, there were in one of the days there were 11 stations which were already there in the library out of 14. So if you master those 11 tasks, even if 3 are new or 2 are new, if you master the 11 tasks, you can clear the exam smoothly. This is how it is important to first plan what you're going to do. All right. So you plan first, then next is practice, actively practice. You cannot say, I don't have a partner. No, you should find a partner. We have a group of 5,000 people. So you can always find a partner. You can always contact me or Dr. Uma or whoever. We can always keep put you in touch with somebody, or we can tag you on the group and say that, okay, so and so is looking for a partner from so and so region. So make sure that you have a partner currently. All right. So now you can start by looking for a partner, and for your foundation building, you have to make a plan for yourself. All right. So that is important. You can even practice during the courses, mentoring. You can practice there as well. In the closed groups also you can practice. So practice is important, and you should start practicing right away. Even in your clinic, if you are seeing patients and you want to take history from the patient, you follow the history template that you use otherwise. Okay, the chief complaints, elaborate on the chief complaints, then the rest of the pregnancy complaints, and then medical diseases, surgeries, allergies, BMI, blood group, reservation to transfusion, smoking, alcohol, drug abuse, support, mental health. Um, yeah, so that would be it mostly. And family history wherever applicable, sexual health wherever applicable, not on all cases. Okay, so these are the things that, see, this is how, why am I able to say it so rapidly? Because of the practice. Okay, so this is how it should happen. By the end of 6 months from now, you should be able to master history taking. Mastering history taking is more important because then you can finish your history taking in 4 months, so that, sorry, in 4 minutes of the 10 minutes time, so that you have 6 minutes for your management. That is why it is important to master the history taking. Now, so what happens 1 month prior to the exam? Take the circuit. Some mock exams are there. You have online mock exams, you have on-site mock exams, you have the RCOG mock exams, whatever you are comfortable with. You take a mock exam. Please don't take mock exam 2 days prior to. We have turned down candidates because one of the candidates approached asking for mock exam a day or two prior to the exam. For us, it was nothing too much to do. We could just take the exam. They would pay for the course and we could just take the exam. But that is not it. It is, I told her that, see, it is not going to benefit you 2 days prior. Please don't waste your money on that. Okay. It is not going to benefit even in the week prior. Why? Can anybody tell me why? Why is the mock exam important? And this is a typical error. You need to take your mock exam well in advance, right?
So that we know the shortcomings of our
Yes,
preparation.
you need the feedback. You need the feedback and you have to work on the feedback. If you don't get the feedback and or you get the feedback on the in the last week of your preparation, when will you have the time to prepare or to work on that feedback? You will not have time to work on the feedback. So that is why it is important that you plan your mock exam somewhere in at least a month prior. That is why RCOG has their course or mock exam a month prior to the exam, to the actual exam, because then you have a month to work on the feedback that is given to you. Few things, like I'll give you an example. We tell all our candidates to start the station with one standard question, okay, rather than, of course, there may be situations where you may need to change the way you approach. Like if the patient is in pain, you cannot just go there, hello, I am so and so, what may I call you? No, you have to first say, I'm one of the doctors here. I'm here to help you. I can see that you are in pain. Are you okay? Should I get you something? That is how. Okay. So, but most of the other tasks would be patient coming to you in the clinic or patient who's comfortable, who wants to talk to you. Okay. There you can say a standard way of opening is, I am so and so. What would you like to be called as? Or you can just say that, what may I call you? One shorter. Why we recommend that you start by saying, what may I call you? Is because sometimes if you say, there is a name given, which is say Sarah John is the name. And this is an easy name to pronounce, but sometimes there are names which are very difficult to pronounce. Okay, and if you have the habit of starting by saying, hi, I'm one of the doctors here, and I believe you are Sarah John. Okay. And if there is a name which is difficult to pronounce, and if you mispronounce and the role player corrects you on the pronunciation, you will get uncomfortable in the beginning of the task. So we tell all our candidates to start by saying, what may I call you? Even if you look at the MRCOG videos of tasks, we do not start by taking the name, unless it is like a teenager who's sitting there, who's, you need to be a build a repo, etc. So you can say, hi, I believe you are Mary, or something like that. Then that's different. For teenagers, you start differently. For those in emergency or in pain or vomiting, etc., you start a little differently. But for all the other stations, you can just say, what may I call you? So practice it. This requires practice. It doesn't come spontaneously. So have your own opening statement. Oh, your own. Plan it, but okay, that's important. So, in the final week, you just have to tell yourself that you have done good enough, you have practiced well enough, and you are ready. Okay, and you practice, keep practicing, keep talking, keep, whether it is your family member, whether it is your pet dog, whether it is a neighbor, even if your partner is not, say, partner has not got booking and you got booking, study partner has not got booking. Doesn't matter. You find another study partner or you find somebody from the family. Just make them sit with you and talk to them, ask them history. Okay. So they may not be able to give you good feedback because they are not a medical part of it, but they would be able to tell you how you're speaking. But it's like a lay examiner assessing you. All right. So have someone that you talk to, or at least look in the mirror and speak. That is something that you can always do. Okay. But I would suggest, now most of you would have clinics, most of you would be seeing patients. So start by talking to your patient in that MRCOG part 3 style. Okay. So that is how you can, that will help you. Okay. So then, one second. Okay. So core preparation principles, practice. Don't read theory. Practice, practice, practice. Okay. You need just the points, because as you are saying those points, the examiner is marking. Okay. In his answer key. Okay. This candidate has said this. This is said. This is said. Okay. And please make sure that your tone changes in the station. For example, there are certain points which are more important than other points. Those certain points you have to emphasize. Okay. And say that this is the thing. All right. And record yourself. This is another important thing that you do. Record and review. What happens when you record your tasks? You record your tasks, you listen to your task, and you are listening to yourself, and you see where you are making a mistake. Are you doing a lot of all those things in between your questions? Are you pausing too much in between your questions? Okay, that happens in the initial part of the practice phase. Okay, so you are pausing too often. That's something that you need to look into. Record and review. Okay. Feedback from your colleagues, feedback from the study group. So we had a group when we were preparing, we had a group of 6 of us. And we had made a small group and we were just practicing and practicing. So whoever was free, okay, come, are you free? We would call them and they would say, okay, I'm free, and I would practice. So that is how we would do. Okay, so it's, you have a smaller group, and then you can if you are joining a course, then you can join the course, but at least have a smaller group for you to practice. That's important. And time, please have, it's essential to have this timer with you. Your phone is there, so your 2 minutes, my phone has a 2 minutes and 10 minutes set in it, because as I'm taking courses, classes, I just put it on 2 minutes and 10 minutes, 2 minutes and 10 minutes. Okay, so that is something that you need to put it on your phone and time yourself. See that you do not exceed. Even when you're sending stations for feedback, there is no point recording a task that lasts for 12 minutes, 14 minutes for feedback. Okay, so you have to finish in 10 minutes. So it's important. All right. Okay, so time management, basically in 2 minutes time, you have to just read what domains, the same thing that we discussed earlier. What is the task? Identify the domains and just approach, like the things, you can make that grid that we discussed earlier, and just try to absorb the information. Okay, it may not be, at least for me, I could not, you know, think of what all points I'm going to say in the 10 minutes time. In 2 minutes, I cannot do that. In 2 minutes time, I need that time to register what is given to me. Okay, so I have read in the first few seconds of the task, I have read it, and in the next 1.5 minutes, I'm trying to process the information. That is what I'm doing in the 2 minutes time. And if there is something really striking, like I give you an example of aspirin with chronic hypertension, that I will write in big bold letters. Okay. In the 4 minutes time, gather information. Now here there is a problem. When you ask information, you're trying to think, okay, what next question, next question. In the bargain, what happens is you ignore what the patient tells you. Like patient tells you, you ask a BMI and patient tells you a BMI is 30. You're busy thinking what next to ask, and you ignore the fact that the patient's BMI was 30, and you do not address it in the management. You will lose there. Okay, if you do not address the basic risk factors that you have identified in a patient, you will lose on safety. Okay, because you have not addressed the risk factors. So it's important that as you're sitting in front of the patient, there's a table in front of you, and you have your notepad with you. The moment you can always have, your pen and the notepad kept in front of you. you should not be looking down, or you should actually make an eye contact. But sometimes when the patient says, okay, my BMI is 30, you write there, make it a habit now itself, right there, you're looking at the patient, but at the same time, you're writing BMI 30, big bold letters, so that later when you're doing the management, make it a habit to just glance through what you have written in the notepad. And that practice has to happen now. Otherwise, in the exam, you will not be even looking at the notepad. So if you practice it in that manner, you will be able to pick on things. Okay, so then information gathering, pick out what you need from the information gathering that you need to address in the management, and make a management plan. 4 minutes for the information gathering, not more than that. 4 minutes is maximum, I would say. Okay. Rest of the task is 5.5 minutes for plan and everything. And in the last 30 seconds, you can just make a maybe tell her about red flags, tell her that I would refer you to the GP back, writing back to GP if it's from GP, writing back to midwife if it is from midwife, and PIL, and discussing with the consultant. But what we tell our candidates is, do not keep PIL for the end. PIL is very important as far as safety is concerned. So say it somewhere in the middle of the task. You cannot always say PIL in the beginning. Okay, a lot of even courses would tell you that start agenda by saying PIL. First of all, setting of agenda takes a lot of time, consumes your time. It is not so important to set the agenda. You can always say that I would like to take a history from you, or I would like to ask you a few questions if that's okay with you, and then we can make a plan. That is fine. But if you keep on saying, okay, I will do this, then I will examine you, I will do this, you cannot know in the beginning of the task that this patient is for examination, not for examination. Not all patients are for examination. You cannot know in the beginning of the task whether the PIL will be available for the task at hand. In the sense, it may be a vague thing. Okay, so it may not be appropriate to start by saying PIL. Okay, in the middle of the management, you can always say, okay, I know I'm giving you a lot of information. I'll give you certain written information at the end. This you can say in the middle. Don't keep it to the end because you may miss it. You may run out of time if you keep it to the end. That is why. Okay, so that's how your PIL is important. Now, yeah, so summarize in the last 30 seconds if you have time. If you don't have time, those are the situations where saying these points, important points in the beginning will help. Okay, so please make a note of that as well. Now, okay. So use every second wisely. Okay, so when you are reading, first thing as we discussed, I'm emphasizing again, identify the type, whether it is a patient simulated task or structured discussion. The first thing, spot the key domains. We have discussed this in detail and why. Critical details of the patient, of the situation, of the body of the task. You have to note like where you are, where the patient is admitted, where is the patient, what is the situation, is the patient in pain. It may be all mentioned in the task, the patient is in pain, or it may be mentioned in the task, patient is extremely anxious. So if that is the case, you are likely to expect a patient who is going to pounce on you, asking you, oh, tell me the report, doctor, please tell me the report. So you need to have a calm, composed manner in which you handle this. You just have to say, do not worry, I'm here to answer all your questions. I would be shortly discussing the report. If she still says, no, tell me the report now, please tell her the report then and there itself. Okay, not a problem. Plan your opening line. We discussed this in detail. And anticipate likely questions in the sense, if you like this as the example that I gave you, if it is mentioned in the body of the task, patient is having decreased fetal movements, ultrasound is done, patient is anxious about the baby, patient is going to ask you in that task, doctor, please tell me about the report, is my baby fine? Okay, so if that is the case, you have to tell her, you have to calm her down. You said, please don't worry, I'm here to help and support you. I have checked your report and don't worry, the baby is currently fine. If it is an IUD, then please calm her down, give her 2 warning shots at least. Okay, like we discussed, the baby is not moving. Is there somebody here with you? Obviously, you have to ask her, baby is not moving. We checked the heart of the baby, the heart is not beating. I'm really sorry to be saying this. It appears that the baby has died in the womb. Lower your tone. Have you noticed how I lowered my tone? That is how you lower the tone and you speak. All right. So anticipation is important. Communication, you basically confidentiality. Things which are important are the ones that are marked in bold. Confidentiality is important whenever there is a situation which requires intimate information or a young girl or a minor who's come to you. Um, always start by saying confidentiality. Don't please don't mind me asking. So, but whatever we discuss here would remain confidential. SRH module confidentiality. Then ask whether it's okay to proceed with questions, permission to ask questions. Always in the beginning, say that I may need to ask you a couple of questions. Is that okay with you? So that this will help us in making a management plan for you. Then you say, could you tell me about whatever? Hmm? Signpost before sensitive information. If she is a case of, say, again, a SRH module or subfertility module, and you want to ask intimate, personal questions. So you, like, for example, sexual dysfunction, okay, things which are likely to embarrass certain patients. So you can signpost. Okay, don't mind me asking. And simple things, signposting, you don't say long sentences. I always tell my people, do not say long sentences. You're wasting time. Just say, please don't mind me asking a few personal questions. End of story. Ask the question. The examiner has already noted that you have said this. Okay. Empathy. Like whenever there is, she keeps on complaining, you just have a particular way of saying, like, say that I'm really sorry to be hearing that, or I can see that you're going through a lot. That would be empathy. Okay. Support wherever necessary. Check her understanding. You cannot just because it is a maternal medicine task, you know, it is a long task, and you cannot just keep on talking. You have to check understanding. Okay, so pause and ask. Am I clear so far? Do not say, "Are you understanding?" That would be like, you're trying to imply that the patient may not understand. No, you say, "Am I being clear? Is this clear?" That is how you say. Check understanding. Any questions? That is how you would ask the role player. Okay. Please avoid medical terms. Make it a habit. Right now, make it a habit. Talking to your patients in clinic is helps you. In fact, right now, earlier I used to not do that in my clinic, but now I just cannot take the medical terms with patient. So I will always say womb for uterus. I will always say neck of the womb. Okay, because that is how the practice has helped. So you start practicing with your clinic patients. Okay, avoid saying medical terms with your patients in clinic and give them information in chunks. All right, strategies for breaking bad news, difficult situations. You have to keep a particular strategy, a particular way of doing it. Okay, my way may not suit you. Okay, but it may suit you. It does suit a lot of people because we keep simple sentences, not complicated. If you see the MRCOG videos, you will realize simple short sentences. Okay. Is there somebody here with you? I have confirmed that this is your report with your name and NHS number. And then say that this is what it is. Okay. Like if you want to say about Down syndrome screening positive. So a lot of candidates will start with genetics. We have chromosomes, we have this, we have that. All that is fine. The way of doing that is first ask the role player, what does she know about the screening? What about the test that she's done? She may say, okay, I was told that it is for Down syndrome. Okay, good, you say. What do you know about Down syndrome? Patient may say that I know it is a genetic problem. I may not know the details, but I know that it is a genetic problem. So you say, yes, it is a genetic problem, wherein we have one extra chromosome, which is thread-like structure, which has a genetic material in it. Okay. And then build on the information that the patient is given already. Like patient has told you, I know about Down syndrome, it's a genetic problem. Don't start with genetics means this, that, it will waste your time. So build on that and then say that I have confirmed that this is your report with your name and your NHS number. And is there somebody here with you? I'm afraid I have some concerning news for you. Simple. Okay, this is all. Then you say that we do this screening test. It is not a confirmed test, but it tells us whether there is a higher chance of having this condition or a low chance. In your situation, it appears that you have a higher chance of having a baby with Down syndrome. Like a lot of people say, okay, 1 in 100 risk is there. So you say out of 100 women, one will have. Rather than doing a lot of drama there, just tell her what it is in a very empathetic manner. So you say that the chance is high or low. In your situation, it appears that the chance of having a baby with Down syndrome is high. However, this is a screening test, which is why we need to confirm whether the baby is actually having Down syndrome. Would you like to know more about it? Okay. Before that, you have to check the background knowledge of the patient, as I mentioned. What does she know about Down syndrome? And if she knows nothing about Down syndrome, tell her what Down syndrome is. Otherwise, there's no point telling a patient that, okay, you have this particular condition when the patient doesn't know anything about it. So this is what should go in your mind, and this is what should go in your practice. It has to be clear, crisp communication to the patient. Okay. Now, um, verbal strategies is signposting, chunking information, checking understanding, simple language like don't say menorrhagia, say heavy bleeding, pauses in between, do not keep talking, 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 talking. No, there are non-verbal cues also, like eye contact. You cannot just look here and there and your notepad and talk. Okay, that is why I said just keep it there. Only when the patient is talking, you can just make a note in big letters and maybe just glance once at the notepad. Make it a habit. Don't keep on looking at your notepad. Don't keep on looking at the question that is pasted on the table. You need to have eye contact, particularly when you're breaking the news or particularly when you're talking to her about certain sensitive issues. Okay. uh, you should not sit like this. Okay, you should have your arms rested. That will also decrease your anxiety. Rest your arms on the table in front of you. Okay, it should not look as if you are, keeping you're not open with the patient. Okay, so it's the posture is also important. Nodding as the patient is talking, encourage her to speak. Okay, that as well the examiner will check. And the facial expressions are also important. Keep a neutral expression. Okay, and the patient is happy about something, you also give her a smile. Oh, that's nice to know. Okay, if the patient is sad, his patient is complaining, you say, I'm really sorry to be saying that, to be hearing that. Okay, so this is how you should actually engage in a conversation with the patient. Do not just do it mechanically. Have a conversation with your role player. That helps. All right. Then the tell, ask, tell. So you give information, ask for questions, and then tell again. Okay. So it has to be a conversation with the patient. All right. So, this is important. You often get questions wherein they ask you, like this is a scenario. A primary gravida at 32 weeks comes with blood pressure of 160, 110. She has severe headache. She's not known to have high blood pressure or proteinuria previously. This is a structured discussion. So first question, one of the first questions would be, the examiner would say, summarize. Okay, if the examiner says summarize, you have to follow anybody knows? What do you have to follow? What
S bar.
tool do you use when you have to summarize?
S bar format.
The
Yes.
SPA tool.
So, correct. So you will use your S bar format. So the situation becomes the most urgent point. What is the most urgent? Can anybody do the S bar in this case? Yeah. What would be the S
Uh,
bar?
May I?
Yeah, sure.
There's a situation of high blood pressure with a severe headache, and with the background of that she is a primary gravida and 32 weeks gestation, which is who is not a
Mm-hmm.
known case of blood pressure and proteinuria. And we would do a quick assessment. We'll take a quick history, and will take a quick history and do a quick examination and send a relevant investigation. And the recommendation would be to admit the patient immediately, and we'll take inputs from the multidisciplinary team, which will involve these senior consultant and also the sleep doctor and other physicians, and we'll make a management plan and further.
Okay. So yes, you were right in the sense you don't have to say so much in detail about the MDT and all those things. You just have to say that yes, this is a 32 weeks patient who's come with severe hypertension and headache, background, primary gravida, previous normal blood pressure, and no proteinuria and all those things. Assessment is concerned about, so your history, you said history, examination, investigations in view of preeclampsia, and the recommendations. Okay, and I would make recommendations accordingly because you have the rest of the task to mention the rest of the points. So don't mention the MDT and all here because then you're wasting your time. So you just say situation, background, assessment. I will make assessment based on history, examination, and investigations. And accordingly, I will make recommendations. So then you can proceed with the recommendations as the examiner asks questions. Okay, so that would be yeah, so common pitfalls is one of the common things that you'll notice as you start practicing is that your history takes 8 minutes and then you have just 2 minutes for the applied clinical knowledge and patient safety. Should not happen. Okay, so allocate time. So these are the common problems. Initially, it will always happen. Don't worry about it. Okay, all of us had that problem. Even I had that problem. Everybody has that problem. Initially, it is difficult to finish that history. Only when you practice and practice good enough, you get that hang of taking history in 4 minutes. Okay, so initially that problem will be there. You need to just practice and get better and better at taking history. Okay, initially you will also have the problem of excessive medical jargon. You will say uterus, you will say cervix, you will say whatever the Dopplers and all these medical terms. Okay, you will also have lack of structure initially. Okay, in structured discussions particularly, even in maternal medicine, we always tell our people stick to the template. Maternal medicine can be done very easily if you follow the template. If you go back and forth, it is difficult. Like maternal medicine, you have to first say that the effects of disease on pregnancy, effects of pregnancy on disease, because you can finish it in one sentence. Because of your thyroid hyperthyroidism, your Graves' disease, there is an increased risk of having a miscarriage, growth issues, early delivery, high blood pressure, effects on the baby, like baby may have a swelling of the thyroid, baby may have high thyroid or low thyroid because of the drugs, or at the time of delivery, or even otherwise, you may have excessive release of thyroid hormone that can cause effects on the heart. After delivery, there is an increased risk of bleeding, and for the baby, long-term problems with attention and social adjustment problems like autism. I've said from beginning till the end in one sentence. So what happens here is, otherwise, if you keep on talking about complications in between, you will say, okay, there's a risk of high blood pressure. I will start you on aspirin. Okay, that part you said. Then you'll say, okay, there is an increased risk of thyroid storm. Then you'll say suddenly ICU. And then you will remember, okay, I've forgotten the drugs that she's on. Then you will come back and say the drugs. And then it will keep on going back and forth and back and forth. And examiner will also not be in a good position to mark you. If you are having a structure, that examiner, remember the examiner is assessing 14 people on one day in those 3 hours. And it is difficult when the examiner has to assess so many of you on one single day. So you have to make things easy for the examiner to grasp. That is also another skill. So you organize your stations. So follow the template well, maternal medicine. Structured discussions, history, information, your investigations, examination. Then in the management, start with counseling, what active management you would do, okay, about the disease management, about the pregnancy management. So this is how you can always organize your tasks. Okay, it helps. Okay. Also, forgetting to check understanding can go against you. Communication, you would be marked down if you don't check understanding. Dwelling on a previous station, very important that if your particular station has not gone well, if you go to the next station, you're still thinking about the previous station. Okay, so that should not happen. Okay, because you're not just that station, the station will also be affected because you are still thinking about that station. So you have to just leave it. There's nothing that you can do about it. You cannot change it. Leave it, go to the next station. All right. So, so what are the various essential guidelines? We all know in obstetrics, preeclampsia is very important, postpartum hemorrhage, preterm labor, intrapartum monitoring, gynecology, heavy menstrual bleeding important. Endometriosis is now, since we have recent guidelines, you may have endometriosis questions, not so common, but you may have. Ovarian masses is quite common. Contraception, SRH is quite common. Emergency, you'll have ectopic pregnancy, sepsis. Sepsis is almost every exam is being asked. Preeclampsia is asked every exam in labor ward stations. So important, collapse. So highlight these important topics. You can make a note of certain important protocols, like we have a video on MOH protocol when there is a major obstetric hemorrhage. What are all things that you do? Communication, resuscitation, investigations, monitoring. This is how we organized it so that you know what to say in communication, you know what to say in investigations, monitoring, arrest of bleeding. You don't miss points. So you have that chart in front of you, paste it on a board that wherever you study, paste it on a board and keep it on top. And every time you can just, when you're taking a break, you just look at it and you know. Mhm. So such things you can do. Then other ethical ethics and safety, consent taking, capacity, safeguarding principles, duty of candor, clinical governance measures. These are very important points that uh, you should not know the details like you did in part two. You should just know the important aspects like incident reporting, consent taking, capacity, okay, safeguarding. These are the important points that you need to know for part three. On the day of exam, make sure that you go well in time. Okay, if you know that it is 1 hour travel to the exam center, please go plan your travel 2 hours in advance. Very important to avoid getting stressed because of traffic and all those other problems. Then dress. A lot of questions are being asked on what dress to wear. There is nothing of that sort. You have to look professional. You have to look presentable. You can wear your sari, you can wear a salwar kameez, you can wear your whatever of your blazer as well. Okay, just don't wear any skimpy clothes and look casual. Okay, don't wear casual attire. Wear something which is decent, which looks decent, something that is not very bright as well. Okay, muted colors maybe I would say. So that would be the thing about dressing. Make sure that you hydrate well. Have a bottle of water. Yes, you cannot carry it along with you in the circuit. They will provide you water. So these are all the last minute questions that the candidates keep asking. So don't worry about all these small things, but make yourself, um, prepared. Sleep well before, eat well. Okay, and between tasks, take a deep breath. It's difficult. One task to the other is almost automatic. So take a deep breath. Okay, it doesn't matter if you've not done well in one or two stations, absolutely fine. You don't know a task doesn't mean you blank out. Okay, it's like a new patient coming to your OPD, a new patient walking into your clinic and telling you something vague. You're not going to say, oh, I've never read that. Okay, you're going to ask questions. You're going to tell her that this is what you're going to do for her. Okay, if there is a situation which may be a little confusing, you may be saying that, okay, I'll consult the specialist, or I'll discuss with the consultant. Okay, if you say that as well, you can still pass the task if you do your basics well. And you have to project confidence. Okay, so confidence comes from preparation. You've trained for years. Trust your clinical judgment and communication skills. Why I'm saying train for years? Because it's not just this. You have been practicing. You have done your OBG. So during your residency, you have been trained. It's not like you know nothing. You know. Okay, so since you know, You should be confident that with a little practice, you will be there on the other side. Okay, so you have a vision. You need to have that dream that I will do it. Positive self-talk. Do not listen to people who would put you down. Do not do that. Say that I'm prepared. I'm competent. I can do this. And say it every day. Okay, you can put it on the board, the same board that I was referring to. Okay, so repeated practice will allay anxiety. It will build confidence. Sleep well in between your tasks. Okay, in between your practice sessions. Don't keep on reading late night. So that would be that should not happen. Now there are various resources. There is RCOG e-learning. There is online courses. There are on-site courses. There are uh, summaries of guidelines, study groups, mock exams. So whatever you are comfortable with, you can choose. All right. So with that, I would like to say that remember, practice beats theory. Do stations repeatedly. All right. Structure everything. Make notes. Even if you have subscribed to a course, make your own short notes and things that you can easily see last minute and go through last minute and revise quickly. So make short notes, simple things like this is how I'm going to take history, obstetric history, medical diseases, surgeries, allergies. Okay, 1, 2, 3, 4. That way. Communicate clearly, very important. Clear. It should not be vague. It should not be too many sentences, too much of information. It should be clear and crisp. Okay. Management of time is most important, and stay calm. That is the most important point. Stay calm. Do not, because at the end of the day, we are all obstetricians, we are gynecologists already, and we know how to take history. So we would know how to approach a task otherwise. Just because this is an exam, it may seem a bit difficult, but it is not so. All right. So trust your preparation, demonstrate competence, and showcase the excellent clinician that you are, I would say. All right.